Hey, it's Coach Taylor from SmarterTeamTraining.com. I've been looking for a lot of information on ACL injuries, weak link programming, and the guy that popped up from a couple different people actually sending me emails was a guy named Dr. Greg Myer. And I'll be honest with everybody on the show, like I always am. I know I've started the show a bunch of times like that, but I got a chance to watch a YouTube clip that someone sent me with this gentleman talking about ACL and movement from a landing mechanic, from a jumping mechanics, etc. And I was really inspired to reach out to this guy. So, Greg, man, I'm really excited to have you on the show here. It's an honor to be able to talk to you. I know you're a busy dude with a lot of things going on, so I'm just happy to get a chance to learn from you, my man.
Thanks for having me, Coach Taylor. I really appreciate your comments, and again, I'm excited to be here and talk with you today.
We sent a couple emails back and forth. I talked to Greg's assistant, and then we literally just got on the show. We didn't do too much talking beforehand. I wanted to really make it a real raw conversation between two professionals that are just interested in learning from one another. So as we go through this, I'm looking forward to learning more from you and more about you. And to kind of get that started, obviously I can look up your bio online. You're pretty familiar with the social media and all that stuff that goes on, so Googling is pretty easy. But I want to know a little about you as a person, man. Can you tell me a little bit about your passion and really what got you involved in the field?
I went to school in college as a math major, and I also played collegiate football, and that's when I first had my ACL injury, and I had my first round of injuries. I had multiple. I had a ruptured pectoralis and other torn labrums and other injuries that occurred, but the ACL was a traumatic life changer for me. It showed me the pathway. I was really into training. As I grew up, I can remember in high school carrying around Jumping into Plyometrics, that little green book by Don Shue. I loved it. I would carry it around. I was really excited about training. I thought training was the best thing. I wanted to be a strength coach, and then I kind of went to college. I was going to be a math major, but then I was really interested in training. And then I had this injury, and this injury really kind of transformed me. I spent a lot of time in the training room. I started to learn about the mechanics that might have been related to the injury. I learned that maybe this injury was preventable. Maybe there were ways that I could tie back into my training, that my original passion. Maybe I could have prevented this, and maybe that would have taken me down a pathway. So that's really kind of the birth of where I've got involved in this. And again, as a normal meathead, I continued to play football past my collegiate years and had my second ACL injury. So that really solidified the need to continue this work and try to figure out how we could actually prevent knee injuries. So my true passion, again, is I love sports and physical activity and creating opportunities, especially for our younger athletes. I think that's something that's falling by the wayside. But I think if we're going to continue to create all these sporting opportunities, we also have to make it safer and more injury-free. I think a lot of our youth are becoming inactive and not developing the motor skills that they need to support sport participation, and that's a concern. So all of these things together kind of feed into my research line.
Obviously, we don't want to get anybody too excited about a traumatic injury that occurs at the knee there, but one of the things I guess I'm looking for is just how surprised some people are because they're not aware of the risk factors or some of the biomechanical scenarios that go on that might have been a precursor or something you might have been able to identify as a potential risk factor for an ACL tear. I mean, talking about some of those predictable type scenarios that often go on in the movement patterns. I mean, what factors have you noticed that may indicate a potential ACL tear? Is there a couple things that stand out to you that when you look at somebody's movement patterns, you say, hey, we got to really pay attention to that?
Yeah, so we've spent a lot of years looking at this and trying to figure out what are the exact predictors or what are the risk factors. What the first risk factor we know is being a female athlete. We know that female athletes are going to have anywhere from 2 to 10 times greater risk to tear their ACL than males, and so that fact alone has forced us to focus on that population and try to determine first what's different about a male versus a female to increase this rate. So we've looked at that, and obviously the first area to look is females' anatomy. They tend to look a little bit different. They may have wider hips. That's the most common rationale that we get in the public, and we've looked at that, the Q angle and things like that, and these static measures, we see that they have a role, especially joint laxity. it tends to contribute to the risk. But again, that falls in that non-modifiable area where there's not a lot we can do about it. So some of these factors we can't really modify. And then these Q angles that we talk about or other anatomical measures, they don't really relate to that female's dynamic movement patterns, so there's not a consistent relationship. So we tend to move away from that. We've also looked at, well, what about the hormonal fluctuations, the circadian hormones in the female athlete? We know they have 28-day cycles. Are these leading to risk? We've looked at that as well. We found that it does tend to have, the ovulation tends to have some effect on joint laxity, as I mentioned, might be a risk factor. And then we've also looked at actual around ovulation, there tends to be a increased risk of ACL injury in the first half of the menstrual cycle, but no real strong relationships. And so we followed up these studies by looking at how does the menstrual cycle affect the biomechanical profile? Does it affect how a female athlete moves? And what we found is a whole lot of nothing. We did extensive testing over 2 menstrual cycles with a lot of female athletes and didn't really find anything with the menstrual cycle or hormones. So that's why we're all coming back to this idea that, again, brings me back to what I'm passionate about is, can we do neuromuscular training? Can we optimize the movement patterns to reduce injury risk? And to do that, we have to know what the risk factors are and what movement does that. And that's exactly what you asked. Well, how can we identify that? Well, the one risk factor, we did a study in Cincinnati where we tested a lot of athletes and let them play their sports with our biomechanical testing, motion analysis, through the whole gamut. We had thousands of predictor variables. The one predictor variable that pulled out that athlete that was going to go on to an ACL injury was that athlete that tend to drop from a box and land in a knock-knee position. So they had a high load pushing their knees in that kissing knee position when they would jump and land. And that one variable was highly predictive of what was going to go on to an ACL injury. So that's an area where we focus a lot of our research on what causes that neuromuscular profile and how can we train to change that high-risk mechanics.
Listening to the YouTube video that was on there and the presentation that was shared through that media format, one thing that I really thought was interesting that I haven't heard a lot of people talk about was the role that and I hate using the term core, but that midsection of the body plays on landing and jumping, for that matter, and sometimes how that loading is occurring at the knee is predicated on how that kinetic chain is either a delivering force or absorbing force, and I thought it was a really cool way for you to describe that. I mean, what role does the core play in ACL management from jumping, landing, and cutting standpoints?
Well, I think that's a great question, and it's an area where we completely ignored it and not really focused our training on in the past. And what happens with female athletes, and again, what I haven't defined is why does this occur, and why does it occur when girls are going through maturation? Well, what we see is females, as they mature at pre-puberty, they're going to jump as high as they're ever going to jump in their life. If we don't do our neuromuscular training, on average, females are not going to adapt. Well, what also happens during maturation is they get increased demands. The lever arms, so their bones, the long bones of their leg, the femur and tibia, the torque on that knee, they grow. Their center of mass gets higher. They gain mass. It's harder to control it. And that's evident as a weaker core. We start to see that females aren't adapting to these increased demands, yet they want to still play high-level sports. Well, what's the symptom? The symptom is evidence is that lack of neuromuscular control. It falls into that knock-knee position. But what's the true modulator of that, the controller of that? It's actually the hip. The hip muscles and the glute max particularly is our biggest muscle in the body, and it's best aligned to actually control these aberrant knee alignments. And that's what we think is our key modulator. What happens, though, if you have a weak core, it makes it more difficult for the hip to function properly, and these loads. So think about as you lean a little bit to your right or left, if you have a little bit of lean, think of how that magnifies the load to one side of the extremity. So if you have this bad mechanic, such as a knock-knee position, when you land and you lean a little bit to the left and you're not controlling it with your hip, think about how that magnifies the load to one extremity, and that's the critical endpoint that actually brings us to the ACL rupture, we think.
Anytime we look at an ACL study, in my mind, I'm also looking at the application from a real-world standpoint, and I work with a lot of teams or a lot of sports that will either brace or tape ankles during competition specifically, and even sometimes at practice. I mean, does bracing or taping an athlete's ankle help or hinder their overall movement at the knee?
We don't have enough evidence to make a really evidence-based statement about that. I can tell you that there was a large study in the Big Ten done with football players, and they actually found that bracing all the athletes, I think it was the middle linebackers, had increased rate of injuries in those that were braced. And then in football, I think that there is some evidence that linemen may benefit from having that lateral and medial lateral bracing, basically when they get fallen on and those types of pressures. But our concern is you brace an athlete and you take away that need for neuromuscular control. So you're using a more static approach to lock that knee in. We're robbing it of its potential to adapt and neuromuscular control and to adapt to the demands needed to play sport. And that's concerning because what happens at time when you're running around without your knee brace? What happens at that point? Do we put ourselves at increased risk? I don't think we know the true effects of that, but our hypothesis is that if you brace it and put on those static and constrain the knee from its ability to adapt and handle the loads, you may be putting it at increased risk. And then we get to the question, well, what about the ankle? Is that should we be locking that in, putting on in a rigid? Because often ankle sprains are more common. But then I think you get to the question as, well, where would you rather have your injury? If you have it, you're putting yourself in that situation, and you're having high loads, and you lock it in at the ankle, it's going to transfer up to the knee, and a knee injury can often be more severe. So I think that the limited evidence we have suggests that bracing is probably not necessary. I can tell you when we do neuromuscular training with our athletes, we don't brace them. We want them wearing shoes that have some good lateral stability, but we also want them not wearing ankle braces and knee braces so that they can really adapt and absorb this neuromuscular control that we think is going to help them prevent injury when they play sport.
I want to keep focused on the ankle here for a second and talk a little bit about mobility of that joint. I mean, how can we increase the mobility of the ankle and or hip to maximize or minimize the forces sustained at the knee joint?
That's a great question. Again, I don't know if we have all the true answers. I think someone like you probably has a lot of these answers and maybe more adept at answering because you have the true training experience and the practitioner perspective. But what we've done a lot of is doing a dynamic stability situation. So we put the athlete in a situation, maybe in a BOSU or an AirX, where they would have to jump and land and absorb those loads, but the loads are going to come at many different angles, and they're going to have to recorrect and kind of adapt to the demands that the unstable surface might provide. And then you can also do many different types of perturbations that will really are the final transition to your athletes by helping them, anticipate or unanticipated responses to the loads of a lateral perturbation. But again, increasing mobility is somewhat more of a difficult task to undertake whenever you have an athlete that can't actually perform the movement. So I think our approach that we do is more in a dynamic task and using unstable surfaces.
I want to talk a little bit about the hamstring and how the quad relationships or dominance kind of reflects that stress of the knee, if you wouldn't mind. And I guess the conversation a lot of people have about what needs to be stronger, the hamstring or the quad, and what kind of protects that knee and what's an enemy of the knee. I mean, how important is the strength of the hamstring, the quad, and for that matter, their relationship?
Well, that's another great question. And being a strength coach, that we don't have any problems with our athletes training our CAN-C muscles. So they like to do their bicep curls. They like to do their quad sets because we like to see that muscle contracting, and those muscles often get 2 to 10 times more training than the muscles that really need it, which is our stabilizing muscles and our posterior chain, our hamstring and glute muscles. So what the mechanism of why it's important for knee injury is, if we look at the knee as a segment, you have your tibia and your femur. The quadriceps is actually going to be the ACL's antagonist, or it's not our friend. It's actually going to pull that tibia forward, which is actually what the ACL is trying to resist. And if you land with a very straight leg, anywhere from knee flexions from 0 to 35 to 45 degrees, the quadriceps is actually putting the ACL at risk. And we've shown in cadaveric studies that you can stimulate the quadriceps with electricity and actually rupture the ACL by just that strong contraction without any hamstring resistance. That quadriceps can actually just tear that ACL away. But what the good news is, we have this hamstring musculature that resists these quadriceps actions, and it actually is our ACL friend. And what we see is that when we get into deeper knee flexions, the quadriceps and the hamstrings work a little bit better together and actually prevent that anterior tibial translation, or the tibia moving forward relative to the femur, which is putting the ACL at risk. But we also see that the hamstrings actually can resist that load on the ACL. So it's an important musculature. So we call it quad dominance because athletes tend to really land in erect positions. They don't like to train in deep knee flexion because it's more work to do. But we really train our athletes in deep knee flexion angles, doing deep knee holds so that they're powerful and controlled in these deeper knee flexions, and they're really recruiting that entire posterior chain from the gastroc to the glutes to through the hamstrings, which becomes ACL friendly. And that effect alone, the public can walk away with 2 key points. If we can keep the knees in a more neutral alignment, so not landing in a knock-knee position, and land in deeper knee flexion, those 2 things right there, if we can train our athletes to do that, you're going to reduce a majority of ACL injuries.
A lot of times when you talk about injury prevention, people are going to go right to the movement screen aspect of it, and they call that preventative medicine, or I guess for that matter. But, when you assess people, are you assessing them on a daily basis, or is it a monthly basis? Is it post-fatigue scenario? Is it when it's rested? What assessments or movement screens are you using to evaluate the knees during jumps, landing, cutting mechanics, etc.?
Well, that's part of the art of having a qualified instructor, and we assess our athletes and are evaluating them with every single movement. Now, we've tried to create evidence-based tools that we can use with video analyses or motion analyses to support the practitioner. We have a tuck jump assessment and things like that to help give guidelines. But as a strength coach, you're assessing technique with every single movement. And those techniques that we're working on are trying to reduce some of these factors that are driving the ACL injury risk factors or correcting it. And so that's why the strength coach is the critical component to everything we do, because they actually are helping break that cycle. If you just take a protocol and hand it to an athlete and say, do this protocol, what they do is that if they have good mechanics, then they're okay. If they have bad mechanics, they reinforce those bad mechanics. And then they start to reinforce those bad mechanics with higher loads as they add resistance. So what the strength coach or the athletic trainer or the physical therapist needs to do is they have to break that cycle first by identifying the factors that are creating that risk, and then also providing appropriate feedback so that the athlete can learn to correct those movements. And I can tell you, for correcting that knock knee position or that valgus, that kissing knee landing, the most important thing you can do as a practitioner is make the athlete aware of it. Record them on their phone, because they have no idea that they do this, and they have no idea that it's a problem. So that's the first thing we can do. But the idea of doing a functional movement screen, or even some of our screening tools, those are supportive. But as a coach, you're screening constantly as they're performing a technique, as they're doing a movement, a jumping task, or they're doing a squat with heavy resistance. you're giving feedback continuously, and that's why people like you are so important to this whole concept if it's ever going to be high-level, performance-based injury prevention training. That's the secret.
I want to talk a little bit about the rehabilitative, and I'll even call it a little bit the post-rehabilitative scenario, which a lot of strength and conditioning coaches or personal trainers are actually involved with. That aspect between the physical therapist and the athletic trainer saying they're good to go, and actually the athlete being, full 100% ready to rock and roll. There is a little bit of a gap, I think, in our field where some people need to, really pay attention to where the athlete really is. Just because they're cleared to go full speed, I don't know if they're necessarily ready to go full speed, and we got to just help the athlete work their way through and get them healthy and ready to rock and roll. I mean, if you recommend any type of squatting post-op, is that an acceptable expectation? I mean, are wall sits, leg extensions, leg curls? I mean, you walk me through a little bit of that process as far as what's really worked for you as far as that post-op and then that post-rehab scenario, and then really trying to transfer people into that back to full speed type gig.
As they were released, the therapists are doing a great job at restoring the function of that athlete, and they're restoring the function in the physical therapy setting of getting that athlete back to having similar quadriceps strength and control during some of the tasks that we see in physical therapy. But as you know, the demands of sport, there's a much greater demand. And so my question to anyone that says that we shouldn't be doing squatting or jumping with these athletes that are returning to their sport, I would question, are we really doing the right thing for these athletes? Because they should be able to do everything that they were doing prior to the injury if they're going to truly safely return back to sport. But what I want to tell you is the secret to returning an athlete after ACL reconstruction. Often they can demonstrate the function and these measures that they need to be released for full activity. But what they have when they're released, if the practitioners are not focusing on the initial injury risk factors, so maybe the practitioner's not really focusing on what caused the original injury, now we have this scenario where the athlete has asymmetry. So they're going to guard or protect that ACL reconstructed leg. They're not going to load it. And our data shows that continuously we find that the athletes tend to guard. Well, what happens is this athlete already has risk factors for ACL injury. Now they have asymmetry, and as I mentioned, lack of trunk control can really create asymmetry, and that's what our primary risk. But lack of loading, so asymmetrical loading, really increases load. So you put the high-risk mechanics plus increased load on one limb, which is going to be the uninvolved limb or the limb that didn't tear its ACL. That's why we see that second injury comes to the uninvolved limb, that second leg. So asymmetry has to be restored, and that's the area where the strength and conditioning coaches can really hone in and focus on, and that's gained by doing single leg training, making them do stability on a single leg. They have to be able to progress to that point. If not, there's some very simple things that athletes do, and it's difficult for the practitioner to pick up. They can land a jump, and they just have like a standard, a small shift in load where they land on one leg before the other, or they move one foot slightly ahead of the other, which can really offset the loads. And these little tricks the athletes get by may let them pass through, but as the demands get higher, it's going to put them at risk. So they need to be able to do all activities that they were doing before the injury with proficiency, but they should also be able to do with them in a symmetrical fashion, and that means single leg activities as well.
With what I'll call an epidemic of young athletes getting injured, unfortunately, at very, very young ages, with the competitiveness that our culture provides, and in the sports as a whole, trying to become the best. We just start them earlier and earlier and earlier. I think education becomes a primary concern, especially when we're talking about parents and coaches that are working with youth athletes. And I'm always looking for ways to try to find a better way to sell the message of not only ACLs, but just a lot of things about training in general. And since we're talking about ACLs, I mean, how can we become more proactive in educating our coaches and our parents and even the kids and the individuals that are going through the training and moving about proper mechanics to minimize ACL injury potential?
That's a great question. I do have to admit that I am a huge proponent of training younger kids and taking it younger, and we train kids from anywhere from 5, 6, 7 years old. But the training I'm talking about is optimizing motor control. What's happening with our population and segments of population is that we have youth that are having less opportunities for free play. They're having less opportunities to develop motor skills naturally. They're having less opportunities for exposure to multiple sports in physical education, or they're specializing earlier and younger so that they're not playing all sports. So motor control is being lost. We have to infuse that motor control in these training strategies with our integrative neuromuscular training programs and do that at younger ages. And this is all done in a preparatory conditioning. It's not a situation where we wait until the season starts or playing sports and, we're going to add in a little training. That's good, but we also have to prepare the athletes. What we often see is young athletes or adolescent athletes, they wait for 6 months, they don't do any activities, and then, it's time for soccer practice to start, and they start from 0 to 100. Well, the coach wants to get them in shape in a hurry, so they run them and do a lot of activity and pack that all into their competition and skill training, and there's no focus on developing motor control, strength, that primal level of strength that our kids are missing. So that's the missing component. So if we're going to get these kids involved in sports earlier, we have to have an equally and matched programming that is focused on motor control and strength and resistance training and those types of activities that they're often missing in the developmental years that we don't see. Those need to become standardized and part of our sports programs for kids. Again, it's a political issue, but we also need to ramp up what we can offer our youth and how much activity they're getting in physical education. That's a whole other discussion, but that's the paradigm that's shifting and really hurting and harming our youth opportunity, and that's why we're seeing this increase in injury risk.
I know you get a chance to present at a lot of different places, and then you're very open about educating others about this field from what I've heard and seen. So my question to you is, if someone's actually in the audience listening to you talk, what's one big motivational message that they could take home from you, whether it's about the field, maybe pursuing the research aspect of ACL injuries or movement mechanics and that type of thing, or just being involved with helping youth as a whole?
The one thing that's the most rewarding area that I've ever seen is if you work in medicine, and I work around a lot of physicians, they go to clinic in their given day, and they have patients that come to them, and some they help, some don't stick to their protocols, they don't do what they're supposed to, and they don't always get better, and it's just not as rewarding. And some children we can't make healthy. There's some things we can't always fix. This is a situation with doing neuromuscular training. It's almost an untapped resource. It's like it's an open pot of gold to increase adaptations for youth, and we almost always, and I can say almost always, but it's always, we get beneficial adaptations, and they're not just an injury risk. The kids start to see themselves performing better. They see themselves moving better, and we see that they see how they're performing better, and more activities become simpler for them. They find more enjoyment out of the movement. So it's a situation where these training programs were successful, and were successful at a very high rate, and so it's very rewarding to work with some of these younger kids. And again, especially working with younger kids that are going through maturation, where they go through that motor moron stage, if you can hit them with some training before that and then keep it going throughout those periods, when they come out the back end, they're just more of a skilled mover. And again, what I think is really important is hitting kids that are younger. Is we see when kids are 5, 6, 7 years old, when they're 4, 5, or 6, they don't care how they move. But when they're 5, 6, 7 years old, they start to see themselves not moving as well as their peers. What happens is they start to decrease their activity. They said, well, I'm not going to do that. I'm not going to look like an idiot in front of my peers. So they tend to pull away. And those are the types of kids that we really like to implement these programs with, to give them that booster shot, per se, if you want to call it, to get them back up to speed where they should be, and really get them integrated back into physical activity and sport, so that the enjoyment's there and they can create a lifetime of being involved in physical activity. And that's what I think is what the most exciting part of what we do. And again, we have to continue. We have a lot of work to do to get that accessible to all kids.
Dr. Myer, for anyone who's listening to this show who wanted to learn more about, again, ACLs, or even to find out more about what you have going on, I mean, how can they go about reaching out to you?
I work at the Cincinnati Children's Hospital, which is an amazing institution that is doing great things all over the world. So I can be reached at Greg, Greg, Myer, Myer, at cchnc.org. I'd be happy to help anyone, give them some of our publications or guidance on how they would implement the programs. I can tell you that we just published an exciting book, so it's really an honor for me because I published it with Don Shu, who's been a kind of an idol of mine ever since I was back in the high school days, starting training. I used to carry his book around. We've just published the book entitled Plyometrics, and that's got all these screening tasks and training youth and training the higher level athlete. It's got every single aspect of the things I've been talking about today, and specifically both rehabilitating and preventing ACL injuries. So I think that's an easy fix, and again, it's an easy title. Remember, Plyometrics. That's an option, but certainly happy to anyone that contacts me. I'm happy to talk to them. Again, I'm passionate about this, and I think I want to keep spreading the word.
Well, Dr. Myer, man, I really appreciate you taking some time out of your day here. Hopefully you heard my keyboard going because I was taking notes like crazy. I'm looking forward to just keeping in touch, my man. Hopefully we can keep in touch as far as a learning opportunity both ways. It sounds like maybe I can help you with some things that we're doing on the practical side, and I'd love to read some research here on a regular basis to find out a way that we can help educate individuals to hopefully protect that knee and do a better job of reducing that risk for others. Again, thank you very much for taking some time out of your day, and I look forward to just keeping in touch, my man.
All right. Thanks so much for having me, and again, I really appreciate the time.